and this is with sensitization, and this is the difference. So it seemed like this enzyme, S-nitrosylglutathione reductase, may be important in terms of in terms of the pathophysiology of asthma, such that high levels would make your asthma worse. So we became quite interested in that in the SARP, following this overall model, in which GSNO made by NOSes would evolve nitric oxide, in part be reported as exhaled nitric oxide, would prevent cholinergic agonist-induced airway smooth muscle constriction. I've shown you some of that, and in some sense would increase beta agonist-induced airway smooth muscle relaxation. At the time we wrote this, we didn't really appreciate the GRK2 story, but that was the overall model. And that the things that would increase NOS activity were many, including VIP, some of the work we did here to increase NNOS activity and increase nitrosative formation. All of that said, when Monica Kraft and Loretta Quay went and did bronchoscopies on a number of patients with mild asthma, they found indeed that there was some association between GSNOR expression and nitrosatiles in the airway, but there are only relatively small subpopulations of patients who might be described as having high GSNO reductase activity in their airways. And these are stable patients, not intubated in the ICU or not in respiratory failure. So we went on and we looked at this in the SARP population, and these are some of the data from the SARP population. So this is GSNOR activity in severe, non-severe asthma and control populations. And you can see the same thing. So there are a lot of patients who have normal activity. The patients who have high activity, we looked at in the SARP database and said, okay, what's different about those patients? So beginning to approach the medical model. They were allergic. They had early onset asthma, so their age of onset of asthma was much younger than those with lower activity, and they had normal lung function. But that said, we may be getting faked out about that subpopulation for this reason. Where you do the lavage can be quite important. All right, and this has come up a lot in our SARP discussions lately. So this is a hyperpolarized xenon image of a patient with severe asthma. And I think you probably have seen these in the literature or done them here, so that if you ask somebody to breathe in a hyperpolarized noble gas, helium or xenon, in these cases this is xenon, you will find that it goes to some parts of the lung but not to other parts of the lung. And this is actually quite repeatable. And so if you come back with this patient a month later and ask them to do it again, up to half of these defects will still be there. So we and the folks in Wisconsin have taken the approach to go into the areas that are well ventilated and the areas that are not well ventilated and to biopsy them. And what we found consistently now, we've done this 3 times in severe asthma patients, that is that when you biopsy areas that have good ventilation, you see a thickened basement membrane and some inflammatory cells, but the epithelium actually looks pretty good in the normally ventilated areas. Whereas in the poorly ventilated areas, the epithelium is denuded. There's a lot more GSNOR expression in the remaining epithelial cells. There's a lot of inflammatory cells under the basement membrane that express a lot of GSNOR. So it's possible that if we go in, or Loretta goes in and does the BAL here, we'll see not too much GSNOR activity because the epithelium is staying on, the expression isn't upregulated. If we go in here, we'll probably see a lot more in the same patient. So that anatomic intra-subject heterogeneity may account for some of the population heterogeneity that we'll see. So what to do? There have been a number of studies, relatively small studies, looking at GSNOR genotype, or ADH5 genotype in asthma, published over the last few years, looking at a relatively small number of SNPs in ADH5 as predictors of asthma in several populations. This is one looking at it in a Mexican and Puerto Rican in two cohorts. I want to point out that the Wu paper looked at triads in Mexico City This is Paul Moore, who worked with Stephanie for quite a while, who looked at beta-2 responsiveness in an inner-city asthma population in primarily African American in Nashville, and found there was a strong gene-gene interaction between beta-2 polymorphisms of GSNOR and polymorphisms of interest with regard to the GRK2 story. And this is a follow-up study looking at gene-gene interactions between beta-2 polymorphisms and GSNOR. And this group actually found that two sets of polymorphisms, one was associated with loss of function and one associated with gain of function. Those associated with gain of function were associated with increased risk of having asthma, both in the Mexican children and in the Puerto Rican children. And so this makes me wonder, in terms of identifying the phenotype of people who have high GSNOR activity, if we might not turn GWAS on its head a little bit and consider SNP-wide analysis of phenotype. Yet another controversial thing that I will say, and that is, if you know that there are particular SNPs associated with gain of function or associated with worse outcomes in asthma, can you ask in the database, in the SART database, for example, what do those patients look like? With whether it's leukotriene metabolism or GSNO metabolism or vitamin D metabolism. So when they walk into clinic, we can suspect, okay, this is somebody who might have a particular targetable issue. How would then we go on if we know from our biochemical assays or from genetic assays what the patient might look like? How would we go about proving it? There are a couple of methods that I'll just go over briefly here. One, I would emphasize that GSNOR serves not just as a GSNO reductase, but also as a formaldehyde dehydrogenase, glutathione-dependent formaldehyde dehydrogenase. Augustine, one interesting thing is that a byproduct of S-formyl glutathione formation is carbon monoxide evolution. And so one of the questions is whether the evidence that we see for increased carbon monoxide in exhaled air in asthma or for increased NO evolution could be related to GSNOR activity. I don't know, not for sure, but this is a group of patients with cystic fibrosis who received inhaled GSNO. And after receiving inhaled GSNO, had exhaled NO measured in a time-dependent fashion. And the squares here are the placebo, the saline control, and the circles are the GSNO inhalation. You can see this time-dependent decay of exhaled nitric oxide as the GSNO is broken down in the lung. I would expect, and we now have some mouse data to suggest that this would be accelerated in patients with increased GSNO activity. So could you give a test dose of GSNO or a GSNO precursor such as ethyl nitrite and measure exhaled nitric oxide over time, the decay, as a test, just like when you give inhaled base and measure exhaled NO over time as a test for the airway biochemistry. Similarly, you can measure breath condensate formic acid levels because formic acid is a byproduct of this enzyme's activity. And in severe asthma, just generically, formic acid levels are high, possibly contributing to some extent to the low pH, but more importantly, I think, reporting ADH5 activity. So these may be tests that you could use in tandem or be developed for the patient who looks like they may have GSNOR increased expression and activity, and you're interested in treating them in a targeted, specific fashion. So again, the phenotype leading to suspected diagnosis. So far, it looks like allergic patients who had early onset asthma but have preserved lung function. We can test the diagnosis with inhaled GSNO or ethyl nitrite challenge, consider treating with GSNO ethyl nitrite or a GSNO reductase inhibitor, and in maybe SARP or in AsthmaNet or in subsequent studies to look at whether targeting this population and treating with repletion in a very specific way decreases their steroid requirement or their symptoms or admissions. I want to close with a caveat about GSNO reductase. You don't get anything for free. and this just came out this month, and that is that GSNO reductase expression is dramatically decreased in a variety of different human lung cancers. And this goes along with Li-Min Liu's data suggesting that GSNO reductase expression is decreased in human hepatocellular carcinoma, and that INOS-dependent nitrosative stress in the liver can cause liver cancer if you don't have the protection of GSNO reductase. So that the INOS knockout, GSNOR knockout combined mouse did not get the liver cancer. And so, but the nitrosative stress I would hypothesize in lung cancer probably comes from cigarette smoke, where you're constantly inhaling 100 parts per million nitric oxide. And in fact, one of the targets that Nadezhda has shown for GSNOR as a denitrosylase is RAS itself, both HRAS and NRAS. And I know this is a cancer talk, is an asthma talk, not a cancer talk, but I wanted to go over this a little bit as a caveat and a reason why we need to just not give this therapy to everybody to inhibit GSNO reductase or give lots of nitrosatiles. So this is an elegant work that was published a few years ago showing that oncogenic KRAS leads to activation of AKT in a classic pathway. And if you knock down eNOS in this system, you don't get oncogenesis. This activation of eNOS by AKT was necessary to form oncogenesis in this system. And also, if you mutated a specific cysteine on HRAS and NRAS, cysteine 118, you also prevented oncogenesis. And it turned out that eNOS was S-nitrosylating this particular cysteine, favoring formation of GTP-RAS and tumorigenesis downstream. That's how the S-nitrosylated RAS was formed, but what Nadezhda showed was how it's broken down. So if you immunoprecipitate the RAS and expose it to GSNO reductase, you lose the S-nitrosylation of the RAS by several different assays. This is a chemoluminescence assay on the IPED protein. Whereas if you don't have GSNO reductase, the S-nitrosylated RAS at C118 is quite stable. And in fact, if you look at, so this effect activates RAS, it's S-nitrosylation, and if you use an inhibitor of GSNO reductase and prevent its denitrosylation, you get further activation of the RAS. You don't see that effect so much in cancer cells. These are wild-type cells, but in cancer cells you don't see it so much because they don't have much GSNOR at baseline. And this is GSNOR immunostaining with some co-localization with RAS. So I say all of that as a caveat that we don't want to use these various treatments that we're developing for asthma, for everybody with asthma, or even large sort of generic subgroups. We need to be very targeted. We need to be very thoughtful about what we're doing with them. And this is an example of some of the methods by which we might apply targeted therapies in severe asthma. Do patients with non-severe asthma need these therapies? No, but by definition, they're doing fine on what they're getting.